Council of Governors meeting. It's an interesting time in the history of the NHS, and it's an interesting time in the history of Swift. This is another opportunity to welcome all of our new governors who have joined us. I'm also conscious of the fact that with the recent council elections, some of our stakeholder governors may change in the future, but in the meantime, it's great to welcome those who have been helping us to date. But without further ado, we'll get going because we've got quite a lot to cover. So we have apologies for absence from Fiona Burton and Ellie. Again, thank you very much for standing in for Fiona. And just in this public forum, I did mention it yesterday, Ellie, but you weren't at the full board meeting. I'd just like to put on public record my thanks to you for standing in for Fiona. Again, you did a fantastic job, and we're extremely appreciative of you going the extra mile for the citizens of Warwickshire. So, Ellie, thank you very much. We've got apologies from Oliver Koffler, Callie Harrison, Bharti Patel. I don't think Holly's joining us today either. Jeremy Shearman and Paramjit Gill, one of our non-executives, is sent apologies. Bless him. He's caught up in the situation in North India with Pakistan. So we wish you, Paramjit, a safe journey home. Any new declarations of qualification for office or declarations of interest? Please raise the digital hand. Robert?
Thank you, Chair. I'm now the SWIFT representative on the Coventry and Warwickshire Integrated Care System Finance and Performance Committee.
Thank you for volunteering for that, Robert. And Adam?
And for the record, I should note I'm also Chief Exec of George Eliot.
I was going to congratulate you on that in just a moment, Adam, but well done on becoming Acting Chief Executive for SWIFT and George Eliot, so thank you. And any other declarations of interest or qualifications of office? Okie dokie. So I think we've had two meetings since we last met. One was the 13th of February Council of Governors meeting, which David kindly chaired, an extraordinary meeting on the 26th of March. If you weren't happy with the accuracy of either of those minutes, could you please raise a digital hand for me, please? I can't see any digital hands raised, so I'll take those as an accurate record. So we'll go then to matters arising and the action update, which is on page 22 of our pack. And I think all of these items are completed. The first was for Adam to assist John Egan in arranging a visit to the Salix project site. That was done. And John, thank you again for your service as a previous governor. Then we had a request regarding assurances regarding our cancer services from Mike Flaxman. That was shared with Mike. We still do have challenges though with our oncology services, and Adam may touch on that later. It was certainly touched on in yesterday's full board meeting. And I do apologise for members of the public who are waiting for oncology consultant meetings. SWIFT, although it's in our building, our oncology consultants are provided by UHCW. All of the nursing, all of the chemotherapy and other services around oncology, we actually do ourselves, but we do rely on UHCW for the oncology consultants. And we are conscious of the fact there are some delays in that process, for which we apologise. There was then an issue around the outpatient letter review group, concerns related to the wording used in endoscopy. I think that was covered off, Adam, so thank you for arranging for that. And then on the patient forum recruitment, there was a concern related to the time-consuming recruitment process for patient forum members. I am very conscious of this, that it takes far too long to jump through the very many hoops that the NHS puts in the way of volunteers who want to offer their time to do things for the NHS. We are unfortunately a victim of national protocols, So I do apologise for those volunteers who have been frustrated at waiting so long for some of the various different hurdles to be passed. And I would just encourage you to persevere, because volunteering for the NHS is a great thing to do, and we in the NHS are very appreciative of it. So thank you. I don't think I've missed any other matters arising. If you feel I have, could you raise a digital hand for me, please? Okay, so I'll just make some introductory remarks and then we'll jump into the agenda. The last few months have been another very, very busy time for Swift. And during that period, we have again been focusing on ensuring that we take ambulance handovers as quickly as possible, and that our standards of care and concern for the citizens we look after are of the very highest level. And I am pleased with the way our A&E teams, our elective teams, and all of the teams in Swift have performed over the last few months. And so I do want to put on public record my thanks to all of them. Can I make sure everyone's on mute, please, particularly those who have just joined us? That's not to say we're perfect. We know we're not perfect, and there's an ongoing process of improvement. In fact, we have next week the Foundation Group Improvement Week, where lots of best practice will be shared across the Foundation Group. And last Friday, we had an operations conference across the Foundation Group, which was a really heartening example of all the different projects that are going on across the George Eliot, Swift, Worcestershire and Wye Valley in terms of driving forward performance. And just as an example, the AI work which is going on down in Herefordshire with Wye Valley is really quite extraordinary, the pace it's picking up. And I'm absolutely sure that will lead to us making particularly our consultants' lives easier on note-taking and other issues. But the thing which came through, not just over Friday, but over the last few months, is the underlying performance of Swift in terms of efficiency is still amongst the very best in the country. Obviously we're in May now, so we finished our financial year at the end of March. We posted a break-even result, a positive £1,000. Every little helps, but that means that Swift now, I think for 14 years, has delivered a surplus and is the only trust in the Midlands to have done so. So again, I thank all of the teams on all of their work for improvement and productivity. We have, as Adam touched on earlier, apologies, we have appointed Adam into the role of Acting Chief Executive for Swift and George Eliot as a result of Glenn Burley moving into a national role as the National Finance Reset Director, which is a very important and significant role as the NHS endeavours to ensure that it gets its finances into a better state, and in particular learns and is able to apply more incentives and consequences for underperforming trusts in the NHS. So Glenn has been working tirelessly on that, and in his absence, there's a NHS England board today. I'd like to thank Glenn on behalf of everyone for the work he's doing, and for Adam for taking up the reins and leading us to a better place. At the last board meeting of Swift and George Eliot, we did decide that we were going to advance with a shared leadership model to address some of the underlying financial challenges of securing both Swift and George Eliot's futures. That work is ongoing, and Adam will keep us briefed appropriately as that progresses. And I think that's it from me, colleagues. Any questions you'd like to ask me on what you've heard? Otherwise, I'll get us into the interesting bits of the agenda. Okay, I can't see any digital hands raised, so we'll move on then into the assurance items. And the first was an update on stroke services that was requested from governors. And I'm really pleased that Martin Sandler's joined us today. And I don't think John is with us, but Martin, over to you.
Thank you. Thanks, Chairman. Thanks, everybody, for having me this afternoon, and for the opportunity to update a little on stroke services. I understand that there's been quite a lot of work and interest on stroke previously. So if I can get my machine to do the right thing, which would be a first. Forgive me. Too many presentations open.
No worries, Martin. You take your time.
Okay, thank you. Dear, it never works when you want it to.
I find that all the time with technology.
Let me see. Right, so I'm not doing very well on this at the moment. Right, there we go. Right, apologies for that. I'd like to pretend this is because I'm so busy, there's so many presentations open on my desktop that I can't see anything. It's a good excuse, I'm going to stick to it. Stroke service update. I understand there's been a lot of interest in this in the past, and there have been updates previously. I'm not entirely sure of the content of those updates, so forgive me for doing a very brief run through where I think we are, and then I'll pick up some of the points of issue at the present time. The stroke centralisation Coventry and Warwickshire was finally delivered in September of 2022 after a very long period. I think it was at least 12 or 13 years of debate and wrangling. Clinically, the service was emulating successful patient-focused services that developed initially in London, subsequently in Manchester, and I've been involved in delivering one in Birmingham around 2012, thereabouts, 2011-12. So we were a little bit behind the curve in many respects. The notion is that there's a centralised acute service. There are peripheral rehabilitation units, which are situated at George Eliot and Leamington Spa, of around 20 beds each, and an early supported discharge service, which seems to be able to allow people home to the tune of about 40% of people get home much earlier than they would otherwise have done. And that's largely the model that we offer here. So Central Acute Service is based at UHCW. The notion, the theory, and in many centres the practice, is it allows people to have access to the interventions that make a difference in stroke, and also allows the focus of acute expertise in stroke. And there are fewer and fewer stroke physicians who are able to become involved in some of these fairly cutting edge interventions, or at least they were in 2012. Most importantly is the notion of acute stroke units, where the coordinated multidisciplinary care does seem to save lives, and it's the only intervention in stroke that's ever been shown to save lives. Thrombolysis, where the clot that causes 85 to 90% of strokes is dissolved by injecting clot dissolving medication, or clot busting, I think was the expression often used. It was a newish treatment, which in many cases, but not all, can be very effective. About a third of people benefit in terms of their function, and they have less disability as a consequence. Thrombectomy is a newer technology and allows essentially, to be coarse about it, vacuuming out of the clot that's caused the problem, and again seems to improve functional outcome. So that's what we hoped for, that's what we did, and we worked together to deliver that. The consultant medical input to the rehabilitation units in George Eliot and Leamington Spa is provided by consultants from primarily UHCW, but although we have our own consultant based at Leamington Spa, the acute unit is entirely staffed by UHCW consultants. And of course, the natural history of this is that the expertise no longer really exists in either George Eliot or Swift to provide acute intervention. So there's no going back in many respects. Oops, wrong one. And I think this has been reported before, we continue to have some difficulties with elements of the service. So at present, UHCW will advise that they are managing very successfully those patients who present as FAST positive. So the face, arm, speech, time advertisement that most people will be familiar with. That is about 75% of stroke patients. It leaves 25% who don't fall into that category. It sounds as though that service is actually quite effective, but it's difficult to know because we struggle to get access to reliable data and there is no direct reporting mechanism, either directly from colleagues at UHCW or from the ICB itself. There is some national data available, so-called SNAP data, which allows some of us to have a little look at what's going on and get some notion as to the service development and some aspects of patient care, including those that probably matter most to the patients who survive strokes, does seem to have stabilised and is possibly improving. The other elements, some of those which I've just described, so the rate of discharge, the ability to manage acute patients, is less transparent. To that end, part of the governance that we agreed when we centralised the service was that there would not only be an ongoing clinical liaison group, which still exists and functions reasonably well, but there would also be a formal review by the Integrated Care Board. And that was due about a year from inception. At 2.5 years on, we still haven't managed that review, and that is a little disappointing. There are also some clinical concerns. So the less clear-cut strokes, the 25% that I mentioned, are often in the back part of the circulation, and they're less clear-cut neurologically. And they really do require specialist input, but they're the people who are not being brought by ambulance to UHCW. They are turning up at their local ED. And of course, there are then some difficulties with diagnosis, but actually also difficulties with transfer. And the routine approach out of hours appears to be, well, keep them where they are, scan them in the morning and let us know how you get on. That's not terribly satisfactory because it means that those people don't get access to acute units, the multidisciplinary care that I mentioned earlier, and they certainly don't get access to thrombolysis or thrombectomy. This focus on fast positive is understandable because it's easy to train an ambulance service to pick up on fast positive, but it does exclude a certain group of patients. The consequences that patients that don't fall into that category do appear to lose out at the moment. There is also a bit of a shift of pressures of diagnostics, of clinical input, and support from clinical teams. What the teams are doing is informally, they're doing a little bit of a clinical sweep and making sure that they contact EDs in the morning and talk to their acute medical colleagues and try and pick up patients and take them under their wings and pursue them. But it's not entirely satisfactory by any means. The other element that does cause a bit of concern here, where managing frailty is so preeminent, is the management of stroke mimics. So a number of older people who will, if they get unwell, they'll become a bit, develop a droopy mouth or be a bit weak or slouch to one side, and they're often picked up as possible strokes. We've noticed that very few of those are transferred back to their parent organisation. So they seem to be sucked into UHCW, but don't necessarily get the benefit of the local frailty service, which may not be in their best interests. We continue to keep contact with colleagues at UHCW and at the ICB. We prompt the ICB frequently, but to be fair, we've stopped hearing back from them when we ask about this issue, and it's something we need to push further forward on. Those are the current issues. A rough overview of where stroke is. I'm going to stop at that point. I'm very happy to answer questions. Well, I think I'm happy to answer questions. I haven't heard what they are yet.
No, thank you, Martin. Suki, is there anything you would like to add?
Thanks, Russell. I think from my point of view, it's probably from a diagnostic perspective, because we still have so much pressure to eliminate all the non-strokes, and I appreciate that. But when it's a centralised service and the patients are coming to the wrong place and we're already under immense pressure, I'm not sure how that works. So that's all I wanted to add in, but Martin's got obviously a wealth of knowledge there.
Okay, no, super. Thank you, Suki. Thank you, Martin. Just before I invite questions or perspectives, I think, Adam, between us, it is important for us to write again to the ICB because it is unsatisfactory. In particular, there hasn't been that review. And I know David's got his hand up, but David has been particularly vociferous on this issue, I know. So questions and perspectives. Jean?
Thank you for all that background. You achieved a lot. I was nominated by the Clinical Governance Committee because they weren't getting anywhere to write to the ICB to get the information about strokes. And although it took me 3 lots of trying, I did get information, and we felt so it's really important that you've given so much detail, because we were given reassurance about the thrombolysis and how quickly they got to UHCW, etc., etc. What nobody's ever given us, and we have asked on many occasions, and I've written and so have the clinicians, is we were told that the thrombectomy, went straight to QE. But when you think how far away that is and how big Warwickshire is, we couldn't see. So we kept asking for audit results and how many there were, etc., even though we knew there weren't many. And we've never, ever got any feedback about audit or about any, results or anything. And it was only because I was not a clinician that I think I was then given the initial information which I was able to present to clinical governance. So I shut up, but I just want to congratulate you on how far you got. But I think it's absolutely shocking that we've had to fight to get this information, and even then, it's really not good enough. Thank you.
Point well made, Jean, and I apologise on behalf of colleagues in the healthcare system who haven't delivered the information we would like. David, before I come to you, Kathy put a hand up as Jean was speaking. Kathy, was it to build on what Jean has said?
No, it's a separate question.
Thank you, Kathy. David.
Thank you. I've been involved in the stroke service in South Warwickshire in particular for a little over 20 years now. And the problem has always been the same, particularly with thrombolysis, where it is ideal provided within 4 hours of the stroke. Now, that is very, very difficult to achieve from South Warwickshire. It's got a disproportionately large size of older population, myself included, and access is very difficult. So by the time people have realised they've had a stroke and think they ought to do something about it, and then the ambulance arrives, 4 hours is long since gone. This is even more difficult because if a stroke occurs during the night, people don't realise until they wake up, which is why the majority of stroke victims arrive in A&E about 11 o'clock. So anybody in South Warwickshire, whatever the treatment, they just, by the time they finally get through all the traffic and up to UHCW, it's too late for them.
Yeah, I agree with the sort of essence of what you're saying, David. I mean, we have similar issues in Herefordshire with Wye Valley, and I'm a little bit conscious of the time. But your point's well made, and I think we need to build that into part of our letter, Adam, to the ICB and UHCW chair. Kathy Wagstaff.
Good afternoon. It's a question for Dr. Sandler. We know we're having problems with collating the SNAP data, and I wondered if there's been any thought of how we could collect that through when we go live with Oracle next year, because I understand that UHCW are almost a year into using it, if that's been thought of.
A great question, Kathy. Do we know the answer to that, Martin? Maybe Adam does if you don't.
To be honest, I don't know the answer to that. I would imagine that we have. There is importance about what data is collected, and there's I think a challenge with getting the right data. So yeah, absolutely. But we've got to go beyond SNAP data to actually be confident that we're getting the right sort of service. So picking up on Dr. Spraggett's point, thrombolysis is possible. It's challenging, and having set service up before in Birmingham, I remember being amazed that we could thrombolyse people from Telford who came into the centre of Birmingham within 37 minutes. I remember thinking, God, we've actually got this right. So it is actually doable with the strength and support of the ambulance service. The other thing that is very important, and a very important point Dr. Spraggett made, the wake-up strokes. This is where thrombectomy would appear to be coming into its own, because the time window is much longer, and there is some evidence that wake-up strokes respond quite well to thrombectomy. It's happening at a very, very low level at UHCW, and a lot, certainly after 3 or 4 in the afternoon, seems to go off to UHB. But no matter how, there is a bit more time to get that done. So there is hope.
Okay, well, really open and helpful discussion, Martin, you've led on that. Martin, if I can ask Adam to reach out to you, Martin, vice versa, so we construct a letter about our concerns to colleagues in the system, building on what Jean and David have said. But what I would say to members of the public who are listening in, the acronym FAST is very important when it comes to stroke recognition, which is if you notice something odd in terms of your face or your a loved one's face, the ability to move the arms, or a slurring of the speech, then telephone, FAST. And if you are able to drive a loved one, going back to what David said, if you are able to drive a loved one, it would always be my counsel to drive to the A&D, and if at all possible to go to Coventry and Warwickshire directly if you are able to drive, but I appreciate that's not possible for everyone. Martin, thank you for your openness. We will take it forward on behalf of the citizens of Warwickshire and keep up the good work. Suki, Martin, you're very welcome to join us for the rest of the meeting, but we'll understand if you've got other things to do. So we move on then to the operational assurance and the quarterly status update report for Q4. Adam, over to you. What would you care to pull out?
Thank you. So the detailed report is provided. I'm not going to go through it line by line, but there are some things I wanted to, excuse me, to draw out. And if I perhaps block them up slightly. In terms of the objectives for last year, the first 3 relate to our workforce, our flexible workforce, and the things we do to help and support our staff. I think there's been some really encouraging work done in the last year. So our turnover rate remains incredibly low. Our vacancy rate is also at one of our lowest levels, and I think that reflects how well the work to recruit and retain staff is going. Also, really encouragingly, we've seen a really significant reduction in our use of temporary staffing, and that's, of course, good for our patients. Having substantive staff who are employed on our wards and in our teams who are able to build relationships with patients is a really important part of care. It's also really good financially. It's reduced the amount we spend considerably on temporary staff. I think the area there's an amber in this section. The area that we still have to focus on is sickness. Our sickness rates remain quite high. It was quite stark yesterday compared to other trusts in the foundation group, that our sickness rates, particularly among nursing staff, were the highest. So that's an area we're focusing on, and we've got a piece of work to review and implement a new sickness management policy, which I hope will be in place in the next month or so. If I move on to the objectives around Home First. So a lot of these relate to the new community integrator service. So this is the transfer of lead provider responsibilities to Swift for our community teams. That involves the services we've currently got and a transformation around them to ensure they're taking a real neighbourhood focus, and also the addition of commissioning responsibilities from some of those services. So all the work there is in place. I think some of the commissioning elements and the transfer of commissioning elements has been a bit slower than we'd expected, but there is now a really good plan in place with commissioning for hospices likely to happen first and imminently, followed by some of the other services associated to the community. So good work going on there. In terms of prevention, we've done a lot with our children and young people's services, and I think there has been some fantastic work in bringing together some of the threads of the work we've got going on across the organisation. We've set up a children's board now, which will help some of that. That's not to say there aren't some real challenges. I think particularly around the number of children with mental health disorders and learning disabilities that we see. That's been a real challenge for our emergency department and our paediatric ward, McGregor. But good work going on there. We've also done a lot to build prevention into, for example, business cases, to make sure we're not just looking at things from a financial perspective, but ensuring that we're really looking at them from a prevention perspective. The next set are around a big move on carbon reduction. If you visited the Warwick site recently, you will have seen all the building work, some of which relates to the decarbonisation of the site through the national grant funding we got to install air source heat pumps and new windows and similar. So huge amount of progress, a huge amount of development work associated with that. We've also been working with partners across Coventry and Warwickshire to understand our role in that, particularly in South Warwickshire, where it is one of our place priorities. And we've worked with partners to understand how we can manage some of that better together. In terms of the supporting pillars, productivity has been a real focus for the last year and will continue to be a huge focus for the NHS. We are up there among the best performing organisations. We've got really low reference costs. That's the value for money effectively in what we're doing. But that's not to say we're resting on our laurels. I think there's more we can do there. We particularly focused on theatre productivity and endoscopy productivity, and those areas have gone really well. But we've also looked at outpatients. We've implemented and are up among the best in the country for patient-initiated follow-ups, which is giving patients the power to decide when they want to return to us. And there's more going on there. I think some of our elective specialties in particular, where we know there have been some productivity challenges, we've really focused on. Ophthalmology is the key one of those, I think. In terms of some of the other objectives, there's some stuff around here around development. So again, if you've been to the Warwick site, you'll have seen the work on the new elective hub, which will open, the first phase of which will open in the summer. We've clearly also got the work going on at Stratford for the CDC and Ellen Badger for the new hospital there. So fantastic work that's gone on with those. We have continued our work on the Excel in Everything programme, and I know we had a more detailed session at the roundtable a few weeks ago, where we talked about that approach we take to our savings schemes, where we don't just look at reducing money, we look at the triangulation of quality, financial performance and operational performance, and really generating ideas from the ground up, which has been fantastic. And again, we delivered a £20 million savings programme last year, which I think is testament to the work of our staff. In terms of the remaining areas on here, the 16th objective on here relates to the quality of our services, and this is always challenging, set against the context of the financial pressures and the really significant demand increases we've seen. We had an unannounced CQC inspection about a month ago, and we're still working through both the good and some of the areas of development that have come out of that. We have some action plans in place. We're working with the CQC to address those, and that work will continue this year. In terms of the 17th objective on here, a really important aspect of our work is research. We recently refreshed our research strategies, and I think we're taking a bit more of a group-focused role. We know that the power of research and the ability to attract research partners is better on a bigger scale, and so we're taking a more group-focused approach to that. And finally, the final objective on here is about capacity. And we've done some work which was reviewed by our board late last year to look at some of the capacity modelling for the future, and what that might mean for our services. I think there's still some work to filter that into our estates strategy, and that will happen this year. But we've also been able to put some bids in for example, expanding our ED capacity based on some of the growth, some really significant growth we've seen there, and we hope that will be successful and we'll be able to do that work this year. So overall, a huge amount that's been delivered this year, largely green on the RAG ratings there, which I think is again testament to the real focus of our staff on driving forward and improving the organisation. And I'm assured that those that are amber, where we haven't had quite as much progress, have good plans in place for the future. I'm happy to take any questions.
Thank you, Adam. Adam, you touched on the community integrated service, and I think it would be good to have a briefing for the governors set up so we brief them more fully on that. Mike, I may have taken the words out of your mouth. Mike?
You just pinched my question, Russell. I've got a question and a comment. My question was, can we have a briefing for the September meeting on the community integrated service? And can we understand what these subcontracts are that have been transferred to Swift and who the current providers are, and perhaps what we think the benefits are of us running it rather than somebody else? But obviously a comprehensive briefing, please, for September would be very useful so we can get into that and understand what's going on. My comment is associated with the objective on young people's services. It's just to say that Healthwatch are running an 18-month project trying to understand young people's access to health services. You may not be aware of that yet, Adam. We've had some interim reports we've had hundreds of responses because we've been going around the colleges and everywhere else talking to people. And what has completely astounded me is the very high percentage, around 40% of the people who respond who can't speak to someone on the telephone that they don't know. They are unable to actually speak on a telephone to someone they don't know. So they have to get their parents to ring up to make their GP appointments and hospital appointments. They find it impossible not to communicate by text. And I find it personally quite astounding, but it's just a comment, Adam, that we will be publishing the report, but not until at least the end of this calendar year, because we've got so much stuff coming in on it. It's very interesting. There you go.
Some would say very worrying, Mike.
It's extraordinarily worrying. It really is.
And is something that schools, parents, grandparents, aunties and uncles should all be concerned with if our young people aren't able to communicate at the most basic level.
Yeah.
The young people's contract is currently up for renewal, so to speak. So we will wait and see the final decision that's made on that.
Yeah.
And Leslie, and then we'll move on.
Just a quick question. What's being done to improve the staff absence levels? I noticed also there's a low uptake of vaccinations amongst the staff.
Thank you, Leslie. Adam?
Yeah, so I think there's broadly 3 areas of this. So the first is making sure we've got the right support for staff. So we're working on some improvements to our occupational health services because we know our staff who are off sick rely on those to help them get back into work. And there are challenges across Coventry and Warwickshire with that. So we should have plans in June for our next steps with that. We've also done a lot of work on our internal health and wellbeing offer. We have a new health and wellbeing lead, and there's some really targeted work going on there to address areas with high sickness. I think finally, I'd say what our managers tell us is that where there are sickness issues, our current policy isn't making it particularly easy to manage those. And so we've updated our sickness policy. It's due for approval in the next month to support managers and staff actually in some of that decision making around sickness absence.
Okie dokie. Thank you, Adam. Thank you, Leslie. We'll move on, and we're on now to the patient experience assurance report. And Ellie, over to you. What would you care to pull out of the report?
Thank you, Russell. So I'm always very conscious this is brought slightly behind time. So this is November to January information. However, I think that is quite relevant because it was our busiest period. So this patient responses were gathered during our time of unprecedented demand. So although there does appear to be a slight increase in complaints, when you contextualise that with the over 300 people we were seeing every day in our emergency department and the ongoing demand on inpatient services and our community teams, that's very positive. We're working very hard to close our formal complaints. We're very aware that when people take the time to write into us to let us know that things haven't gone well, we need to respond. And so we're putting in processes to monitor those on a weekly basis now. I always like to pull out about our volunteers. They are so invaluable to us. There is a myriad of volunteer roles. We always welcome more volunteers, and I think it's really important to highlight them in our report. And then just to say that we changed provider late last year at very short notice. Our provider withdrew for I Want Great Care for friends and family feedback, but we very quickly got I Want Great Care up and running. They're not fully where we'd like them to be yet, but we're hoping by September we'll be there with two-way SMS text messaging, going back to your point about younger people, and that should really support with us getting some some immediate feedback. And those are the main things I wanted to put out.
Great, thank you, Ellie. Thank you for your leadership on this. Any questions to Ellie on the patient experience report? I have to say to members of the public watching, I get lots of feedback from a variety of sources, and Ellie, certainly 90% of it is very positive about the experience that they've had at Swift and the care. So again, an enormous shout out to our frontline staff, but we know we don't get everything right, and when we don't, and certainly when it leads to a complaint, we apologise and always endeavour to do better. Okay, we'll move on then to the finance assurance report, and I did mention that we just scraped over the line, Kim, earlier, but what would you care to pull out of the finance assurance report, please?
Thank you, Russell. So yeah, we did. So we delivered our statutory duty, which is to break even. So we delivered a £1,000 surplus. So it was very tight. We had some real challenges managing the position during the year, specifically around the fact that we were not fully funded for the National Pay Award. So therefore, we were expected to absorb and manage that risk internally, and also we had to obviously put in the right staffing levels to ensure that we were safe to cope with the additional, to ensure that we had the capacity to deal with the extra activity that we were seeing come from all over the place, really. So I think, you know, we've done well to deliver our financial position, although we didn't hit the financial plan that was set. But just to remind people, really, you know, and governors, that it was a stretch plan that we'd set at the beginning of the financial year. Within that plan, though, there was an expectation that we would deliver £20 million cost improvement programme, and again, that was a really challenging position to do during the year. But again, you know, the outturn was that we did achieve that, albeit you know, a significant proportion of that was via non-recurrent means. And hopefully, after the training session this morning, most of the governors understand what I mean by that. But again, we delivered that with you know, additional income by ensuring that we were making sure that we were coding things correctly, counting our activity correctly where we could. The estates transfer to and facilities transfer to Swift CS was a big contribution to our CIP delivery, and also the work on drugs and various other schemes through our Excel in Everything programme. So I do want to take the opportunity really to thank all the divisions really for working together on delivering that position. The other thing to notice around agency, and Adam touched on that, you know, our agency spend last year, the year before, 23-24, was just over £17 million. And in terms of 24-25, we managed to cut that by half, you know, to £8.5 million, which is obviously a massive achievement. So I'd like to thank, you know, Bhaskar, Jack and Ellie and the teams really for their leadership in driving that spend down, which is a real feat by reducing that spend, but again, maintaining our you know, safety for the organisation. So thank everybody for that work. The other commendable thing is around our capital programme. We had a significant capital programme of over £40 million last year, and again, you know, all through the year, it's, you know, it's quite tight to actually manage. But again, towards the end of the financial year, everything was delivered by the end of the financial year, and we hit that plan as well. So again, that's a big credit really to our estates teams in terms of facilitating all the relevant moves that's necessary, and to ensure that we deliver those projects according to time. So really, I think a concerted collective effort for the whole organisation that really shows in financial terms. Our cash position, we ended up in the £17 million positive position at the end of the year, but you will note that we are running with a higher level of creditors at the end of the year than we would like, but clearly we're just managing our cash and our liabilities and debtors in a tight way to ensure that we've got the right balance. So I think that's all I wanted to draw out, Chair. Thank you very much.
Thank you, Kim. This success doesn't happen by accident, as I'm sure governors will be aware. Any questions or perspectives? Okay, we'll move on then, as I can't see any hands raised, to the clinical governance assurance report. David, what would you care to put out as chair of clinical governance?
Yeah, there's one thing. There's actually an error on the 12th of March, 12th of February is a report. In the positive assurance to the board, it's the CQC patient survey of ED that was a positive outcome. They didn't actually visit the ED in February, but they did visit the community and therapies. So that element is correct. Other than that, I'm comfortable with it being as read.
Thank you very much, David. Any questions or perspectives to David? Thank you for your leadership, David, and thank you for your support as my new Vice Chair. We'll move on then to the audit assurance report. And Robert, what would you care to pull out?
Just a couple of things there, Chair. We're continuing to keep an eye on the diagnostic waiting time internal audit review and the follow-up actions associated with that. We can see some improvement on that. We undertook a review of external audit, and generally there is a positive view of our external audit service. So I think that was really just the main two. Everything else that is there for information.
Super, thank you, Robert. Any questions or perspectives to Robert as chair of the audit committee? Okay, well, we can then to the governor representatives on different projects and groups. And first up is the Community Diagnostic Centre project. Nice to see some photographs in the report, Mike. Anything you want to add to the report?
No, I take the report as written, Russell. It's been a very impressively managed project in my view, and I'm extremely impressed by the speed with which the services are moving into it. It's just impressive. You know, they're going to be moving in 3 days after they take practical completion. I said to Jane, are we going to do a pretty quick clean? And she said, absolutely, over the weekend. But starting services on the Monday following practical completion on Friday, I think is astonishing. But there you go. It's been a great project, I think.
Well said, Mike. And I think, to be honest, Adam sort of touched on it when he did the review. Our estates team, led by Sophie and others, do a remarkable job on all of these projects, and in particular on the elective hub work, which we'll touch on in a second, jiggling everyone around. But on the Community Diagnostic Centre, anything colleagues would like to ask? Okay, well, thank you, Mike. So we'll move on to the elective hub project. And David, welcome. Anything you'd like to pull out of your report? Again, we like photographs.
Unfortunately, this I didn't get the invitation to the meeting, so that report has been produced by Mark. The invitations are all now sent as of Monday, so from now on I'll be able to talk about what happens in the elective hub project, but unfortunately they didn't manage to get me to a meeting before this one.
Okay, apologies, David. Hopefully the next meeting occurs before it actually starts to open. But as you can see from the photographs, members of the public, real progress being made. It's still very red, but it's almost ready for action. So any questions on the elective hub project? Okay, and then our first sort of big piece of big piece of building work is the Ellen Badger redevelopment project. Mike, anything you'd like to pull out?
Thanks, Russell. Yeah, just really we're talking about commissioning in the second paragraph, and if all goes well, then the first patients will be attending their first appointments in June. So fantastic. We're not far behind everyone else, even though we started earlier.
Yeah, and I really hope that citizens in Shipston come to appreciate the facility and the advantages it brings to the local community. Any questions on the Ellen Badger project? Okay, thank you very much, Mike. We'll move on then to the End of Life Committee. Michael.
You have my report. I don't think there's anything to add to it, other than what I usually say is, once more, I'm impressed by a committee that is interested in improving the situation all the time, improving the methods, and mainly embedding end-of-life care on a good scale throughout the hospital. Particularly, you'll see that they're now thinking in terms of awarding each ward or some of the wards either gold or bronze or something, depending on what has been embedded in the ward. I would encourage actually all members, because I do think this is a terribly important issue, to help embed it in the hospital throughout. It's doing very well, but any help is welcome.
Okay, thank you, Michael. And just before I invite questions or perspectives, I just want to build on a discussion we actually had at yesterday's board meeting, which was around the respect form. I really would encourage members of the public that, and we all know when we're at that sort of age, to make sure you filled out a respect form in the way you want your end of life care to be delivered. You know, even to the extent of whether you actually do want to come into hospital if you're unconscious. So respect forms are a really very powerful and frankly a legal necessity for us to be able to provide the end of life care that you want. So I know it's not a popular subject often to discuss within families, but if you want to ensure your end of life care is exactly the way you want it to be, please do fill out a respect form. Any other questions to Michael?
I think I'd add to that, Russell, actually, particularly before perhaps you're under the pressure that requires its existence.
No, absolutely, Michael. So, apologies, just bear with me. Technology is letting me down. Back with you. So any other questions to Michael? So we'll move on then to the Falls Prevention Steering Group. David?
Thank you. I'll take the report as read. Happy to take any questions.
Thank you. David, any questions to David on the Falls Group or Falls Preventions Group? Okay. Leslie?
I was curious that one ward has significantly more falls than others. I wonder if it's the nature of the patients or the staff. I didn't know which it was. It was farriers.
It will be the nature of the patients, Leslie. Yeah. Ellie, is there anything you want to add to that?
Yes, Farry sometimes has high level of falls due to the nature of the patients. So they have some frailty patients on there. They also have younger haematology patients, and they sometimes fall because they're normally fit, independent people, but are very unwell at that point, and so are used to be able to do things for themselves. And so we do find they often get up without asking for help and fall. We don't tend to react if there's a high number of falls just in 1 month. We look for trends and themes with falls. So we do see often with wards, they might have one patient that falls several times, so that it looks like they've got a high number, but it's very, very important we don't just sort of react to that number and we actually understand what's going on behind it.
Thank you.
And the whole management of falls, Ellie, you'll be far more experienced in this than I am, but it's a challenge when patients' hopes and expectations about their physical ability to stand up and walk around isn't matched by their frailty or the fact they've suffered some functional decline whilst lying down. So it is always important, if you've got a loved one in hospital who's maybe a bit frail or has been in the hospital bed for a while, to take the advice of the nursing team as to how mobile the individual should be, because it's better safe than sorry. Falling over is not good for any of us. Colleagues, happy to move on? So next on the agenda is the Health and Wellbeing Hub Steering Committee, but Carolyn, I don't think there's anything to report, is there?
No, the next meeting is Monday, 12th of May, next Monday, and I'll report after that.
Okay, look forward to that update at that point. And similarly on the Medication Safety and Optimisation Committee, Tim, I don't think there's anything to report on that at the moment.
No, the next meeting's on Monday.
Okay, super. Thank you, Tim. Look forward to the update then. And Holly, on the Patient Experience Group, I think you're in the same situation.
Holly's not with us today, Russell.
Okay, in absentia, Holly's in the same situation, so we look forward to Holly's update at the next Council of Governors. So we will move on then to the Patient Safety Surveillance Committee. All sounds very Big Brother. Carolyn?
Yeah, Big Brother. That's been suspended pending review of the meeting format. So this report is simply a digest of the report I received from January 2025. Obviously, there was no meeting, so I can't explain it any further. I understand that it's waiting perhaps for Fiona, who now I think is back, thank goodness, to decide on the format and the dates of the meeting. I'm told May or June.
Okay, look forward to that coming back to us then once that process has covered off. But is there anything on the report the colleagues would like to clarify or ask?
I think if
Okay.
there is, then it should be Ellie probably who would know more about it than I do.
Okay,
But,
I can't see any hands raised, so you can relax, Carolyn.
okay, thank you.
So we'll move on then to the Radiation Protection Committee. Paul, anything you want to brief us on?
No, I've only been appointed as a governor very recently, and I haven't yet attended any Radiation Protection Committee meetings or indeed received any material. So I'm not in a position to say anything at the moment.
Okay, Paul, we'll look forward to you going to one of those meetings, and we'll just make sure with Verity and Sue that all the I's are dotted and T's are crossed. So if any meetings occur, you're invited. On safer discharge, Jean.
Yes, we've had some. We had a cancellation when it was the critical incident on the day, and our next meeting is next week, and they're bi-monthly. But I just want to reassure everybody that it's a really important element in the care and the management of patients and the hospital's achievements. And this committee really, really works hard, and everybody invests in it, as I'm sure Ellie will support. And just as a sideline, blood bikers, which might be a surprise to some people, now take tablets to take out, tablets that weren't ready at the time of discharge, but we don't want to keep patients hanging about waiting for tablets. And another improvement is that all wards have now got a dedicated pharmacist, which makes sure that all the medical drugs, etc., medicines are all up to date. So really, really pleased. There are some issues about patients being lost to follow up, and we're looking at that as part of PCC and safer discharge. And we've already mentioned that, I think, earlier on. So so I can't praise them enough for the effort that they all put into it. Thank you.
No, thank you, Jean. And the point you make on the importance of early discharge for patients and safe early discharge is really important to our flow. We are incredibly busy, as Adam's indicated, in our A&E departments, for us to ensure people spend, if they need to become an inpatient, as little time as possible. We need to have free beds. For us to have free beds, we need to ensure that patients go home as soon as it's clinically safe to do so. And I know for some citizens, there's a sense of, well, it's best for me to be in hospital. When it's clinically safe for you to go home, it's best that you are at home, because the evidence for physical hospital-acquired functional decline is really very compelling. Hospital, if you should be up and about, is not the best place for you. So thank you, Jim, for your work in this area. Any questions or perspectives to Jean? I'd just like to thank again our Blood Bikers volunteers. They do a great job. They really do. And, you know, I know some of them, and I can't thank them enough. It's a very important area of work.
In the critical incident, they worked in A&E through the whole thing to support them because of the emergency.
Yeah, absolutely super. On the Salix project board, I don't think there's anything to report, is there, Michael Cox?
No, nothing to report. I think we've got a project meeting tomorrow, though.
Okay, it's all happening over the next few days on these meetings. I'm looking forward to the next Council of Governors meeting for the update. Similarly, on the Serious Incident Review Group, I think that's the same situation. Michael, just so you're aware, I'm spending time over the next month or so with our security team at SWIFT to see how we handle situations of violence towards our members of staff. And then on the Wayfinding Strategy Group, back with you, Michael. Anything you'd like to pull out here?
Yeah, I'd like to, I take the report that I've written as read, if I may. The only thing I'd like to say is really this Wayfinding Group does spread across a lot of the projects that we're dealing with. So it touches every sort of area we're working within that have already been mentioned. And I'm looking forward to trying out one of the wayfinding boards.
Yeah.
See if I can get lost.
And the Living Maps work is still progressing, isn't it, Adam?
It is, yes. Some of the screens are already up and there's more to be installed over the coming months.
Yeah. I think the Living Maps work is really good. I'd encourage members of the public to use it. Any questions on the wayfinding work? Just like to have a shout out to Roger Lloyd, one of our previous governors who did a lot of work in this area. Roger, in absentia, thank you very much. Colleagues happy, therefore, to move on to some governance matters. The first is the General Purposes Committee approved minutes from January the 9th and the 10th of April. Mike, anything you particularly want to pull out of these?
No, I think people who've been in the meetings will see the output of the work that's done in these. So just take any questions if there are any.
Thank you. Any questions to Mike on the GPC minutes from those two meetings? Thank you, Mike, for your chairmanship of them. The Patient Care Committee approved minutes again from January and April. Jean, anything you'd like to pull out of these?
Not really. It's been some time since we've had a meeting. Everybody's really investing in it. We've got new governors on it, so I can't wait. We've had one meeting with them where we've set out the different rules. But the one thing that people who might be newly listening to this meeting is the patient concerns and compliments, so that if they've got any issues or they want to say thank you to any of the staff, then please approach me or approach anybody in the trust, and they'll come to us and we will record it and make sure that action is taken according to whatever they wish and to what level.
Okay, super. Thank you, Jean. Any questions to Jean on the Patient Care Committee? Okay, fantastic. Thank you. And then I think we're on to the Membership and Engagement Committee update. Mike Ross?
Yeah, this is actually paused at the moment because the public engagement strategy at the trust level is paused. I think that's handing back to Ellie after Rebecca picked it up because Fiona was off and everyone's back in place now. So, but that's paused because the lead provider and care collaborative processes may actually influence the way we engage with people. So they want to get that understood first.
Okay, super. Based on Mike Flaxman's comments about Health Watch and our younger citizens preferring texting and digital interaction, I think we need to make sure our strategy takes account of that. Anything from Mike on membership engagement? Okay, I think we're then on to the Register of Governors and Governors' Interest, the annual review. Sarah, over to you.
Thank you, Russell. So this report captures the Register of Governors for our new council and all of the interests that have been declared. Thank you everyone for completing your declaration of interest form. Both of these registers will be published on the Trust website, so they're here for receiving and noting. Thank you.
Okay, super. Thank you very much. And any questions or perspectives on that item and those papers? Thank you. So we'll move on then to the report on resignation, appointment and election of governors. Again, back with you, Sarah.
Thank you, Russell. I'm happy to take this report as read, and just to note that we have got 2 vacancies since the new council was elected, but we're going to hold those vacancies for the time being. So this report's here for receiving and noting. Thank you.
Super. Thank you, Sarah. Any questions or perspectives on those? Just because you mention it, I do want to publicly thank Izzy Seacombe, who was leader of Warwickshire County Council for a number of years. Whatever one's political positions are, Izzy, in my opinion, was an extremely effective leader for Warwickshire, and I would like to thank her on behalf of the Trust in the way she promoted partnership working across the healthcare system. So Izzy, thank you for your public service, and we wish you well, and all the new all the new councillors who have joined. If they want to have any briefings and are watching this meeting on YouTube or on the Trust website, please do not hesitate to reach out to us so that we can help you be more effective in your role going forwards. The Council of Governors schedule of business for 25-26. I'll take as read, but anything you wanted to add, Sarah?
Just that we can vary the schedule as required, deferring items or adding to, so it's here for approval. Thank you.
Okay, so if you're not happy to approve, could you please raise a digital hand for me, please? Okay, duly approved. Thank you very much. Then we're on to the annual review of the Board of Directors standing orders, all 29 pages of it. Anything you would like to pull out of this, Sarah?
They're just minor amendments and to bring up to date with current legislation. Thank you to Roger Lloyd for his help in doing the review with me. They have been through Audit Committee and also the Board of Directors, and they've approved the proposed amendments that are here for the Council's ratification. Thank you.
Okay, and then so if you're not happy to ratify those standing orders, could you please raise a digital hand? Okay, duly ratified. Thank you very much. So I think, therefore, we're on to any other business before I come to question. Any other business from governors? First of all, any questions from governors that they would like to ask? And any questions, therefore, from members of the public? Okay, well, I think that brings the public meeting to a close. Just like to wish everyone well, and for my governor colleagues, we will have a 5-minute break and then we will get into the confidential board. So look forward to seeing you in that. Thank you all very much. Take care.